Thank you, everybody. I'm going to say hello to everyone and welcome us to this discussion today for our Public Health Lunch and Learn, Mapping Liberatory Futures Through Stories of Public Health Practice. We have some wonderful speakers with us today who are bringing diverse perspectives on public health work in a range of different disciplines and also geographies. We have people connecting from on the West Coast and as far as Ontario as well. And myself, my name is Lindsay DuPré, and I'm one of the PHSP faculty members. I'm an assistant teaching professor, and I am connecting today from Haudenosaunee Territory in Southern Ontario. And so this event is part of an event series called Future Pathways and Career Networking series that PHSP, the School of Public Health and Social Policy, has been hosting in collaboration with our Student Association. And this event series has been going on throughout the past year, where we've been bringing people together to talk about public health and social policy and different priorities for conversations that we wanted to have in regards to our careers and how we're understanding the world of public health and social policy evolving. So today's topic around mapping liberatory futures is something that's very, very important to me, particularly as a Métis scholar and community organizer and mom and auntie. And in all these roles, I'm really thinking about how my work is embedded and supporting or connected to broader movements of liberation for Indigenous peoples, but also in thinking about how it's connected to many other liberation struggles and movements as well. And we're going to talk about a few of those today. Before I move on to further introduce the conversation and get the panelists starting, I wanted to hand things over to the PHSP Student Association to share a few words from their perspective. Katie?
Thanks, Lindsay. My name is Katie. I'm going to introduce also Matsuko and Fiona, who are in the PHSP Student Association. It's 2 years old now, and we get funding through the UVSS if we continue. And we've been able to fully cover things like the public health virtual conference registration fees. And we are currently looking for one more representative to continue. The Discord server is for students to chat and in their own space. And and we would like that to also continue beyond a semester. Sorry, you guys, I got nervous all of a sudden. We have monthly drop-in virtual socials for informal synchronous chats, and we collaborate with PHSP for events like this. And we also collaborate with other student groups for campaigns like Access for All and Mask Up UVic. And we do want to mention that being a director isn't a huge time commitment, approximately 2 hours per month, especially if we have more directors to share tasks with. And you can stay on for a semester at a time. And you can do more or less work just depending on your availability. And we also decide on what we can use the funding for from the UVSS. And so if that is of interest to you, I can put the links into the chat. And I also wanted to mention how the PHSP program places the emphasis on social justice throughout our courses. And so having events like this with the social justice lens is giving us an opportunity to deepen our understanding of health equities and health disparities, and having speakers that can give us practical examples of how they apply their lens in their practice is just such a great opportunity. So I wanted to thank everyone for putting this together. Thank you. Thanks, Lindsay.
Thanks so much, Katie. Yes, shout out to you, to Fiona, to Matsuko, and also Zachary Derrick, who's another member of the Student Association and has led this work with us throughout the past year. It's been a really enjoyable experience collaborating and thinking about what types of conversations are most valuable and interesting to us and important for us to have as we move into, for students moving into their careers, and also for those of us in further along in making sense of our work. On the call today, this event was open to students, faculty, staff, and also broader community members and alumni. And so however you are connected to us, or if perhaps you just found this event through social media, we're grateful for you to be here. And although we're not going to have a live discussion with all of the guests in the space, we know that you all are bringing very important perspectives as well, and important work that you're doing in your practice. Okay. I'm going to share my screen here for a second. To get us started, it's been somewhat commonplace over the past few years for land acknowledgements to be done within events and courses and different spaces. For me, without opening a can of worms of all of the tensions and debates around the purpose of land acknowledgements and the usefulness of them now, I do want to offer that in spaces that I host, I find it really important to, ensure that the ways that we're acknowledging place and we're acknowledging land are connected to the actual knowledge that we're engaging with. And today it's very important and very relevant for us to start by thinking about the realities of settler colonialism and how historically and onto today and into the near future anyways, we're dealing with settler colonial violence, and that shapes health inequities in many ways, not just for Indigenous peoples, but for all peoples living on these territories. So this artwork that I'm sharing here today is going to help me open things up in that way to ground us in an understanding of Indigenous presence on these territories, and also, how Indigenous knowledge perhaps can guide us in making sense of our work in public health and our pursuits of liberation. So this work was created by Osanej woman and Coast Salish artist Sarah Jim. Sarah Jim came into relationship with our school, and through conversations with our faculty and staff, came up with this beautiful artwork that is showcased in the lobby of our office when you walk in the doors. So for anyone who's in Victoria, and if you're interested in checking it out, you can go to the PHSP office in the HSD building. And Sarah's artwork is all about the interconnectedness of nature, of water, of all the different parts of ourselves and our relationships to these places. So I'm going to read the artist statement that goes with this. And then after that, I'm going to hand things off to Parker, our first speaker, who's going to share about the work that Parker's doing. And, not to put you on the spot, Parker, but if there are connections you see to how I've opened things up, I hope that this work will help guide us in our conversation today. So Sarah writes, "What an honor to create this piece for the folks at the School of Public Health and Social Policy at the University of Victoria. The themes they had in mind were relationships, collaboration, community, connection to land, and balance. I wanted to honor those ideas by creating a piece that depicts the interconnectedness of land, sea, and sky. The moon in the center reminds us that life is cyclical and does not move in a linear path. We're constantly changing and experiencing different phases. It also pays homage to the Wasanich 13 moon calendar, and I really like the calm, feminine energy that it radiates. The plants are all local Indigenous foods and medicines to this territory. I always like to honor their significance by depicting them in my art. There are added Coast Salish elements within their leaves to symbolize their importance and acknowledge that the culture is informed by the land. The blue crescents and trigons can be seen as ripples in the water of the four directions. These are common shapes in Coast Salish art. And the raindrops are representative of nourishment. It's what makes the land lush. It's necessary for all life. We have an origin story of the first Wasanich man who fell from the sky with the rain, so all Wasanich people are descendants of the rain. Thank you for trusting me with this creation. I love playing with the color and challenging myself with trying to make this painting as clean as possible." So I have lots of thoughts of what that means in relation to my own work, but I want to hand things off to the panelists to hear about what your practice looks like and how you're thinking about your relationship to broader liberation movements. Parker, would you like to go first?
Sure. Thank you. Yeah, thank you for the opening us up with that beautiful statement. I think that there are a lot of intersections in the work that we do. And when I think about indigeneity, and I think about place, what it means to be here, what it means for me to be here, I think that it's really important that we consider our positionality in that, and we're constantly learning about our impact to each other, but also the land, and feeling excited about learning Indigenous ways of being, learning about Indigenous cultural safety. I grew up here, and I'm actually calling from the Lekwungen territories. I'm originally from Savannah, Georgia. I'm an adoptee. And growing up here, I mean, most of you who are here know that it's already not the most diverse place. But more insidious than that, they didn't teach us about Indigenous ways of being, and they certainly didn't teach us about Blackness. And so it's been a process in seeing how things have shifted. And I feel really excited about the work that's being done in my communities and how the youth are showing up and leading the way. So yeah, I do think that there's a correlation there. But when I think about social justice and the ways that it's shifted in my work, I took some notes to answer some of these prompts, these really thoughtful questions. As I said, I'm originally from Savannah, Georgia, and I'm an adoptee, and I think that really set up the way that I do my work. And it led to volunteering, just trying to do the cliff notes, just, volunteering around town, whether that was at our place or Seven Oaks mental health tertiary facility. I ended up studying psychology and minoring in education at UVic. I did outreach and community inclusion. Short after that, it was like 6 years of that work. So I'd be working with vulnerable youth in group homes, in semi-independent living, and adults with different needs in that space while I was still studying. And that led to youth mentorship of fellow adoptees of African descent. And a lot of that came from while I was finishing up university. I'd started this platform called This Is Table Talk, and I did that in collaboration with a dear friend and brother of mine, Vishnu Pinwani. And we spent day in and day out together studying and grinding and trying to, crack the code that is university and make it through. And we recognized that people who look like us didn't have a lot of opportunities to get together and talk about the things that were relevant and the challenges that were coming up. So, racism and discrimination, challenges in the workplace, finding work after graduation. These are the kind of things that we wanted to focus on. And it started off as a men's group called Link Up in the Students of Color Collective building. And it soon evolved quite quickly to a larger thing. We went to Quench Culture Club on Fort Street before it moved, and we said, hey, we want to run these sessions, bringing large groups of people together, marginalized groups, to talk about these themes. And they just threw us the keys and said, absolutely. And so we started hosting them every single month, and they'd be different themes: racism and discrimination, challenges in the arts. We would focus on queer identities, and we would use this mechanism called the kitchen table mechanism, which is an Indigenous way of being in space. And we'd have a table in the center and a witnessing circle around the perimeter, and people would just, they'd be able to visit and listen, but we would focus on the communities that the theme was about. And so the first session was like 30 people. The next session was, 40. We got up to 60. We changed the locations. We went to Open Space Gallery downtown. That was like our largest public session. This was pre-COVID, of course, but it was a lot of people. And we realized that, sorry, that's just my partner leaving. This is Zoom. This is the Zoom world, right? So we, I live in an old house and it's very squeaky and drafty. And so it just grew. And we realized very quickly that this is a space, this is something that people really needed. And when I reflect back on that work, it took me a long time to learn the language that I needed to really advocate for myself and others. And I could see earlier on in my life that there were injustices happening all the time. They're in school. I would experience them daily, whether it was racism, discrimination, or some other form of microaggressions. Teachers didn't know how to advocate for non-white students. I remember at one point, the vice principal at the time told me that there wasn't enough of us to celebrate Black History Month when I had asked. And I know that these experiences shape the way that I do my work. I never planned to be in this position of hosting events in support of marginalized demographics or anything like that. And I guess seeing and experiencing injustice made me feel like I was in the Matrix. Neo unplugs and he sees that there's something much bigger going on and it's affecting all of us. And as a collective, I think there are really deep wounds, and I hear it in the way that we introduce ourselves. I hear it in the way that we acknowledge land. I hear it in the way that we describe ourselves. And I believe that we're still trying to figure out how to be in community. And it can be really awkward and messy and uncomfortable. And I think that if we continue to create spaces where people are able to define what safety means for them, and for them to share their stories and celebrate their history as they position themselves in this colonial system that continues to oppress us in blatant and insidious ways, that's where change is going to happen. I think the goal of Table Talk was to lessen the distance between groups of people and social issues, create an opportunity to learn from each other, because we're always go, 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 go. We live in an individualistic society. We don't make time for each other. We're not accountable to each other. We don't need to be. We pay our own bills. We do our own grocery shopping. We don't depend on each other the same ways. We definitely don't depend on each other the same ways that our ancestors would have depended on each other. And I think that is done, it's to our detriment. And I think now, with my work as an organizer and a facilitator, I'm trying to move away from sitting just in the themes of oppression. And I'm trying to focus on joy and defining safety, as I said before, and celebrating people's stories. But I notice a tendency from participants and even myself during events that highlight big themes that we just stay there. And we call it the trauma Olympics. Like my friend and I, we kind of joke about that. Like we're all just running laps around this track of existential crises and sadness, because there's so much going on and we're so connected through our tech that I really do think that it's not always helpful. I oftentimes I'll go to an event, I'm like, where's the food, where's the music, where's the laughter? Like there's so much to celebrate. There's so much amazing work that's being done. And I think that this pandemic has showed us different ways of connecting and being, and that we can achieve our goals, and come together and make space for each other. And I think that social justice is a big term, and in many ways it can be thought of as a buzzword, but it's embedded in the work that we do. And I'm continuously thinking of the ways to create inclusive space because of my own positionality. I'm constantly checking in with myself to determine how I'm showing up and how I'm challenging my ways of thinking that have been programmed into me, whether that's neurotypical ways of thinking or ableist language or facilitation. How can I address these different needs? And I could go on, and I hope that we can get into more of a conversation as well around this. I'm curious to hear from the other panelists as well, but this work it's a lot. But we are in it together. I believe that we have an obligation to create relationships, and so we're in this together, and I'm curious where my work will take me. So thank you.
Thank you, Parker. You know, as you were talking, something that stood out to me, linking back to the mandala we showed at the beginning, was this idea of what nourishes you. You know, Sarah wrote about how the raindrops representing that in that piece, and doing this work and hearing you talk. You know, thinking about there's the hardness and there's the violence that we're coming up against on a regular basis, but it's how do we support each other? How do we engage in that collaboration and ethics of care that can nourish us to keep going and to dream up futures that are different and not grounded in pain. Thank you. I'd love to throw things over to Gillian next. Gillian, would you be able to introduce yourself and tell us about your work?
Sure thing. So my name is Gillian Kolla, and I am currently a postdoctoral fellow at the Canadian Institute for Substance Use Research at the University of Victoria. I'm coming to you today from the lands of the that are covered by the Treaty 13 with the Mississaugas of the Credit. My research also takes place on the territories of the Anishinaabe, the Haudenosaunee, and the Huron-Wendat. And I am a public health researcher who works on issues around substance use. And my focus in the last few years has been around interventions to address the growing overdose crisis across the country. Just taking a step back for a second before I talk a bit more, I just want to acknowledge that when we're doing land acknowledgements, and especially myself as an uninvited white settler on these lands, I would be remiss if I didn't acknowledge the deeply racist roots of drug policy and drug laws in our country, the ways in which these laws have been used to maintain colonial histories and colonial relationships, of dispossession of people, of Indigenous people in Canada. And I also need to acknowledge that the drug toxicity overdose crisis has disproportionately impacted First Nations, Métis, and Inuit people across the country as a result of these both historical and continuing impacts of colonization. I also just want to acknowledge, as I'm getting started, as I was putting together my slides today, whenever I put together pictures of people who I've spent the last few years organizing with, I get really choked up because oftentimes there's people who I have very deeply cared about and lost to the continuing drug policy crisis that we're facing in this country. And so I just want to acknowledge as well the community members, friends, and family that many of us have lost to the overdose and drug policy crisis that we're facing. As I continue, Parker, I really appreciated what you were saying about sharing stories of hope, because I find that these days I'm really often taken into a space where there is not very much hope. Things have felt really hard for the last couple of years. And so I wanted to today take a step back and think of some stories and examples of hope, and where, as a researcher, I'm not under any illusions about the fact that research is going to change the world. Or even sometimes make a small change. But I did want to find some examples of where coming together as a community to care for each other and to show care for each other has been able to have a lasting impact. And so I'm going to tell you a bit of a story about how we developed overdose prevention sites in Ontario. And I'm going to tell you a story about like a big thing that was really visible and really out there in the open. And then I'm going to talk a little bit about some of the smaller and behind the scenes work that we sometimes do, especially by listening to people in our communities, in my case, people who use drugs, that we can have continuing and lasting impacts as well. I'm going to take you back to the summer of 2017 in Toronto, when we had 3 supervised injection sites that were still not open, but they had been approved by the federal government. Fentanyl hit in Ontario about a year after it hit in BC. We were a little bit later in terms of getting some overdose prevention sites up and running, but there were several organizations that were ready and gung-ho to get going, and they couldn't get funding from the provincial government, despite the fact that we'd seen an upward trend in overdose deaths for the past 10 years, and a huge amount of direct advocacy and community action trying to call attention to these deaths and the need for interventions to address it. And when I say that the overdose and that fentanyl hit in Ontario around 2017, we saw a 46% increase in overdose-related deaths between 2016 and 2017. And so in the summer of 2017, I come from a direct service background. I was a social worker and counselor for years before I came back to grad school in my 30s. I was working in Toronto. I was doing my PhD research, and I spent a lot of time in community during my research. I'm an ethnographer. I was spending time in spaces in community where people were gathering to use drugs. And all of a sudden, there was just overdoses all over the place all the time. Community members were talking about this. Frontline workers were talking about this. We were trying to hold emergency meetings with public health, trying to get something happening. And the graph that you see on the right there, we didn't have it at the time, that's showing that spiking upwards, but we knew it. We could feel that something was changing, that something was different. And in fact, we found out later on when, the data got counted that this was in fact a moment we were seeing a huge spike. And there was a huge amount of frustration and action at the government stalling that was going on as members of our community were feeling the direct effects of this. And so a group of people came together to start the Toronto Overdose Prevention Society. This was a group of volunteers comprised of people who use drugs, frontline harm reduction workers, a couple of researchers like myself, all volunteers. And we decided one day to just do it, to just put up tents in a park where we felt was really an epicenter of where overdoses were occurring in the city. And one really important lesson from the people who use drugs that we heard about right at the very beginning was that we didn't know how the police were going to react when we first put up these tents. And so they asked, and they wanted to be very, very crucial and pivotal in the midst of the organizing and running this site. We really wanted it to be a space where people who use drugs felt at home. But the first couple of days, people didn't feel comfortable being there because we weren't sure if the police were going to come in and arrest people. And so one of the things that they asked of those of us who didn't have criminal records, who had a couple more letters behind our names, those kind of things, was that we were at the front in the beginning, putting our bodies on the line just in case there was going to be police intervention and we were going to be the ones arrested. Once we found out that the police actually were okay with this happening, we did a bunch of negotiations the first couple of days, then we actually moved more into the background, and we really privileged having volunteers and people who use drugs be the ones who were very, very central in the sites. So we ran the overdose prevention site in the park as a volunteer operation for 11 months before we were finally funded by the provincial government and moved inside. We ended up having just over 9,000 visits to the overdose prevention site in those 11 months and intervening in 251 overdoses. Now, this led to a number of very, very immediate impacts. In fact, within the very, very first week that we opened up in August of 2017, the provincial government sat down and negotiated funding agreements with 3 of the organizations that had previously gotten the federal approvals to open sites. And in fact, Toronto Public Health opened the first official supervised injection site just over a week after we had opened in a park just a few blocks down. We actually really moved quickly. There was a policy window that opened at that point. And so we were really involved in pushing forward the overdose prevention site model in Ontario. And 15 OPSs managed to open in the year after we opened for the first time in a park across the province of Ontario. This was actually people moving very quickly by design, because in the summer of 2018, Ontario switched provincially to a conservative government. And at that point, things changed very dramatically, and there was a real slowdown. I won't tell that story today. That's a story. I'm trying to remain hopeful. But I think that the really big point here is the importance of direct action, and really getting out there when it's necessary and doing something big to try to make a difference in our communities, listening to people who are using drugs, the people most effective, but then really figuring out how you can come together and work together to try to make a change. Now, as a researcher, one of the things that I was responsible for at the site was keeping the data on the site. And we really tried, as we were going through with the OPS, to keep the site very low threshold, follow community practices, not put too many rules in place. And in the sites that were scaling up across Canada at this time, because this was the period where we were seeing very large scale up across the country, There was a rule put in place by the federal government saying that peer-assisted injection, so having somebody else help you with your injection, wasn't allowed. We were a couple tents in a park, so we didn't see the need to follow along with this rule. So we had no rules on whether you could assist somebody else splitting or sharing your drugs, or where you could inject on your body, which is all things that were often subject to different rules in the federally sanctioned sites. And we heard a lot from community as sites were opening across the city that people who relied on others to help them to inject, who needed assistance, weren't able to do that in the sites that had opened up. And this was something across the country, in fact. And so we kept data on peer-assisted injection in our sites. And being, a researcher, a public health student, we wrote a paper about our findings. It turns out that women were 2.4% more likely to access assisted injection at our site than men were, and that they were 2.2 times more likely to overdose when they did access assisted injection. And so we published a paper about this, and we started to use this to really call attention to the fact that the rules that Health Canada had put in place banning assisted injection within supervised consumption sites was actually directly impacting a particular group of people, in this case, women who required assistance to inject. Because if an overdose occurs within a supervised setting, like an overdose prevention site, there's rapid response available. By not allowing people who required assistance, this means that you're literally leaving them out in the cold. And so we argued to them that these rules might be disproportionately harming a particular group of people, in this case, women. And so we actually then started to do some advocacy behind the scenes with Health Canada, talking to them about the results of our research and about the implications of this. And it turned out that they listened to us, and they actually removed the ban on assisted injection in supervised consumption sites across the country, which was a very small policy change. But it was nonetheless one that came directly from people who use drugs, who were trying to access services and having a hard time with it, and that was really important to them and to the community, and that we were able to make a difference with. And so again, I just want to highlight that we were really I was trying to figure out what I could talk about today that was actually these hopeful stories of times when people came together to try to move on particular issues. Because again, I think that we do need to find hope in the work that we're doing, not overstate it or oversell it, but also just say that, sometimes we actually can have a difference in the work that we're doing within public health.
Thank you, Gillian. Oh my gosh, 10 minutes is not a lot of time. I know that you could share so much more with us, and I just want to thank you for your work. You got me thinking about this idea of the work not being linear, which again, bringing things back to Sarah Jim's work, that the moon can teach us that, and thinking about how we need to always be ready to show up in ways that community needs us to. And that's not always maybe what you thought it was going to be as a student, whether, for you in social work and then public health, or, we just have to be ready and to show up creatively wherever we can. Yes, thank you again for sharing with us. John, do you want to go next? And then if we still have some time afterwards, we'll open things up to the three of you for anything else that you want to add.
Sounds good. Thank you. Okay. So my name's Jonathan Herriott, and I'm coming from Toronto. I work as an HIV physician as well as a family physician at a place called Church Wellesley Health Center in downtown Toronto. So there I specialize in being a family doctor for those who are living with HIV, as well as doing a lot of HIV prevention work and addiction medicine and things of that nature. I also do some part-time work at a hospital called Casey House, which is a hospital that specializes in caring for people who are living with HIV and those at risk for getting HIV. So with the first question of just sort of how has my understanding of social justice evolved through my career, the first time that I think I had a real breakthrough with understanding social justice is when I got into medical school. I met a guy named Dr. Ryan Miley, He's a physician and author that was a bit of a mentor of mine during medical school, and he taught me all about the concept of the social determinants of health. And so these are things I'm sure most people are familiar with, but things like income, housing, education, race, gender, that really have an impact on people's health outcomes. And through learning about the social determinants of health, it gives us doctors sort of a way that we might intervene in these areas on patient interactions, as well as looking more on a societal level and how doctors could be involved in advocacy in these areas. And building off that, when I moved to Toronto, I got involved in a group called Health Providers Against Poverty. This is a group of doctors, nurses, all other healthcare professionals who work on advocacy around raising the social assistance rates, advocacy towards more affordable housing, increasing the minimum wage, workers' rights, and things of that nature. And then as I started working as an independent physician, I started to focus my practice a little bit more and focus my advocacy a little bit more into areas that were under my direct expertise. So working towards universal coverage for HIV prevention treatment, which we still don't have in Ontario. I know in British Columbia, things like HIV treatment and HIV prevention are universal there, but we don't have that in Ontario. So it's an important area that I think about a lot. As well as expand. Another advocacy project I'm working on now is expanding access to HPV vaccination, which is something that's really important in my work. And then I have also, as my practice has gotten a little bit busier, I've tried to focus more on what I can do on a patient, sort of direct patient interaction to help my patients reach their health goals. And I think that brings me a bit more to the next question, which is, what does social justice look like in my practice, and how do I sort of fit this into my daily work? And I wanted to bring it back a little bit to the social determinants of health, because in my practice, really it's income, it's people's finances that are their main barrier to reaching their health goals. And so I wanted to talk a little bit about the 8 ways that in my practice that I focus on social justice and help my patients who are experiencing poverty reach their health and happiness goals. So number 1, I think it's really, really important for doctors to just have a non-judgmental approach. We have patients that come from all walks of life that have had all sorts of experiences, and I think it's important to be welcoming to these patients, even if they might be challenging to deal with, as well as just be a space where they're able to feel comfortable and access healthcare. Number 2, if I'm going to help my patients who are experiencing poverty, I need to know who they are and know about it. So there's been a push in the area of the field of family medicine to be asking more of our patients about income, and there's actually sort of these direct screening tools that have been developed. So that's a really important thing that not all doctors are doing, but it's important for us to be doing. Number 3, I think as doctors, we actually are in a unique position where we can directly increase the income of our patients. And so it's important for us to know the ways we can do this. Some of this is a little bit Ontario specific, but in Ontario, I can help my patients apply for Ontario Works, which is basically the main social assistance program here, to get them started with $700 a month. And then if they qualify for the Ontario Disability Support Program, I can take time out of my day to apply for this and then get them an extra $500 a month. And then there are additional programs, including the special diet allowance and transportation allowances that we as doctors can apply for our patients and get them additional money on a monthly basis. And then this is a federal program, is the disability tax credit. So when I have patients that have certain disabilities, making sure that I support them through the application for this program to get them more money so they can, have less financial barriers to health. And so if I'm working to if I'm working to increase my patient's income, I also have to make sure I don't decrease my patient's income. And this is something, unfortunately, in many family practices, there are a lot of fees associated with having a doctor. Sometimes there are doctors that charge no-show fees, or they charge fees for filling out paperwork or giving someone a doctor's note. And so in my practice, when I'm thinking through a social justice lens, if you're working with the patients that I work with, you just can't be directly taking money away from patients by charging fees for these sorts of things. So I think this is really important. When I've done my best to try to increase my patients' income as much as I can, I think the next step is making sure I have social work supports that I can connect my patients with, especially my patients who are dealing with housing insecurity or they're underhoused. I think that's where referring them to a local social work or caseworker organization that can help them with housing is really, really important. Number 6, because we still do not have universal pharmacare in Canada, I think a great financial barrier to patients is just accessing their medications. And so some of the most important ways that I get my patients free medications are through there are programs, compassionate access programs for HIV treatment, which are very important for me to understand and be able to navigate for my patients. PrEP, or HIV prevention treatment, like I said earlier, is still not covered in Ontario. And so knowing how to sort of navigate a patchwork of programs to try to get my patients usually temporary access to free PrEP, so that those at risk of getting HIV do not acquire HIV. That's really important. And then also just having a very well-stocked sample closet. So many important medications for my patients are not covered by provincial healthcare plans or other insurance plans. And so in my specific practice that I work with, having access to things like antihistamine medications, erectile dysfunction medications, some laxatives, probiotics, and things like that, that can be quite expensive for patients, but having a well-stocked sample closet is important for those things. Other things that can be very, very expensive for my patients but are not covered are things like physiotherapy, mental health support through counseling and psychotherapy, vision care, and dental care. So as a doctor, it's really important that I know my community resources, know how to access these things for free or for low cost for my patients. And then finally, just making sure that in the work that I'm doing, that I'm caring for those who need it most. And in HIV care, some of the largest gaps in care are for newcomers who have just arrived in Canada who don't have any form of insurance, as well as refugee claimant patients that have a different form of health insurance. That's a federal program called the Interim Federal Health Program. So I make a priority in my practice to be accepting patients that come who are uninsured or have refugee insurance. And I think that's really where a lot of my most important work gets done. And so just as a quick recap, these are some of the ways that I think myself, but probably all physicians in Canada could be taking a more social justice or health equity approach to their patients who are dealing with financial insecurity. And thank you for listening, and I look forward to the rest of the panel discussion.
Thanks so much, John. Yeah, we have, just under 15 minutes left, and there's so many threads of what you each shared. Although you're working in very different areas, there are those threads. There's those connections between what you talked about and your practice stories of how you're trying to do social justice oriented work. I have a few of those ideas, but I wonder if the three of you, if any of you have things that come to mind that resonated from what each other shared that you want to help pick out for people that can help us tell the story of how public health in all its interdisciplinary areas of work, how is public health connected to broader liberation movements? What are you hearing from each other's stories? Anyone want to go first?
I would love to just jump in real quick, because listening to the both of you, the amazing work that you do, I have so many other questions, but also I'm reminded that the advocacy is required. Like you have to get at the advocacy from all angles, and it can look different for everyone. And you need people who are working on the inside. You need folks who are in academia. You need folks on the front line. And I guess one of the biggest questions that came up for me as just like a participant for a moment there is how do you care for yourself in this work? Like that, that's a lot.
Parker, I appreciate you asking that, because I think one of the things I really appreciated in your presentation, I mentioned this earlier, was kind of like the idea of trying to come together to share stories of hope. I was at the memorial for a very, very much loved community member, not last weekend, but the weekend before. And it was a community gathering. We tend to do community gatherings as Indigenous sharing circles, and it brings everyone together. And people were coming together. It was, because of COVID, there hasn't been as many opportunities to gather together as community. And it really, really, everybody kept saying, oh, it's so good to see you. Oh my goodness, we only ever see each other at memorials like this. So I do need to underline that sometimes this work is just difficult and devastating and so hard. I try to really infuse an ethos of how communities can come together and care for each other into my work, but I'll be honest, it's been very, very difficult over the last little bit. And I do need those moments of like reminding us, of how to come together. The other thing is, and Jonathan, you kind of alluded to this, I mean, I happen to have a very privileged position. I have benefits. I pay a lot of money every month for a very, very talented trauma-informed psychologist to help keep me together. A lot of people don't have access to that. And so I think this continued advocacy to make sure that we have those services available. Everybody should have access to the highest quality psychotherapy. Like the trauma that we see in our community, the trauma that's ongoing in our community from the overdose crisis and the devastation it's causing is huge. And people there just isn't enough of it. And so I think that you're right, keeping on pushing that advocacy forward to keep on actually like making these small dents and making so that we can, figure out ways to care for each other and have the services available for people that they need them.
I wanted to say another thing that when you say, how do we care for ourselves? When I first got involved in the Health Providers Against Poverty organization, this was, multiple years before COVID, the meetings were in person, and it was all these incredible individuals coming from all these different health provider backgrounds. And we would be talking about projects and advocacy work and things we were doing. But then at the end of the day, I always had this theory in my mind that part of the reason everyone was attending these meetings every month is it was almost just like a support group. And also like we're all these busy people working in the hospitals and you don't see each other enough, and then you come together once a month, and it was almost half support group, half advocacy organization. And I think since the meetings moved online, I think some of that has been lost for sure. And I hope there'll be a day someday soon. I'm not running the meetings anymore, but I hope someday soon they'll be brought back in person in a safe way for everyone.
Another question for the three of you. When I open things up in framing things around acknowledging Indigenous presence, longstanding presence on these territories, and ongoing settler colonial violence, with that, a point I was hoping to make or come back to now is around how entangled these different social injustices and environmental injustices, the injustices that we see in this country and globally as part of a international global colonial project, how deeply connected experiences of injustice are. And so, Parker's work, especially around mental health, and Gillian, your work around substance use and overdose, and John, your work in HIV prevention, and I'm oversimplifying your areas of work, but these to some would seem like disconnected or separate issues or topics or areas of public health practice. But I think what we're hearing through your stories is that they're very much connected. So I'm wondering if you could speak to that and how thinking about it in that way might help us in actually building momentum in the movements we're a part of. Whoever wants to go first.
I just had one initial thought that I think like the obvious connection for me is like HIV and where it's, the populations that have been affected most by HIV are, I think, some of the populations that have just come up during this conversation throughout. And like, whether it's, people of color or Indigenous populations or those using drugs, or a lot of the patients I work with more in the LGBT community, I think, the these different sort of interconnected injustices is very clear in the work that I do. And then looking forward, we have the technology and the medicine to prevent anyone from getting HIV ever again, but we're not doing it. And I think in North America, at least, when people talk about who is still getting HIV despite access to HIV prevention and despite access to PrEP, like in the States, I think it's a lot of gay men of color and people who are using substances. And then in Canada, I think we're not using PrEP a lot for people who are injecting substances. And then again, it's people who don't have access to a good healthcare plan. Those are the folks that are still getting, still acquiring HIV in our country. So yeah, these things are just very obviously interconnected for me.
I do have thoughts, but Gillian, do you?
You can go ahead, Parker.
All right. Yeah, I'd previously done work with the low security prison on the island here at William Head, and I co-facilitated book clubs at talk spaces with one of my mentors, Dr. Lisa Gunderson. And I had joined the Existence Project after I finished doing outreach. And it's a small organization that focuses on reducing stigma and humanizing homelessness and advocating for the human right to housing. And I was motivated to continue that work with William Head because of the direct pipeline to homelessness that is associated with being incarcerated. And it's just astounding to hear how little we prioritize some of our most vulnerable folks, and how we once you do something that you even if you end up in prison, you are judged for the thing that you did rather than who you were or who you could be. And that is something that the men talk about all of the time, is that fear of how can I reintegrate and where are my supports when I come back after I'm doing the work to try and reintegrate to a community that will, push me off to the margins or discard me. And so it's just, there's so many links to the work that we're doing. And I've worked with people who are directly experiencing what Gillian and Jonathan are supporting or working with as well. It's really wild.
Gillian, do you want to share some last thoughts before we wrap up?
I'm just going to go off of what Parker said a little bit. I mentioned earlier that I've been trying to find hope in the work that I'm doing because it's been particularly difficult. And I've been casting the net very, very large. I've been trying to kind of think about whose voices are we not hearing, who isn't speaking, who isn't at our tables, and why aren't they there? I've been working a little bit on trying to figure out how to support people in the community around the impacts of overdose. And this actually brought me back to a lot of the literature that was being written by gay men in the late 80s and the early 90s, before antiretroviral medications came out, when they were experiencing just huge amounts of devastation within their communities. And so it's been really, really interesting to read those accounts and to hear from those voices as they were struggling with the same questions of how do we rebuild our communities amidst, government, inaction, feeling like our lives aren't valuable and worthwhile. The other place where I've really found a lot of inspiration is in the work of Black women scholars in the US around abolition and movements towards abolition, and really, thinking about the impacts of criminalization, the carceral prison complex, and the ways in which this has been having just deep and lasting effects on communities, and primarily Black communities in the US, for a very long time. And so sometimes it really helps me to think that we don't necessarily always have to reinvent the wheel again. Sometimes we just have to really cast a large net and see how other communities have come together in difficult moments and at difficult times, and to see how we can learn from them and borrow strategies from them as we try very, very hard to move forward to create better futures and support our communities.
Thank you. Yeah, just to close us off, close us up, in addition to thanking you all, I'm grateful for my colleagues in PHSP and all the students and alumni, all the people that are part of our broader community, the community partners that we have. There's so many people that are engaged in this work, who are really trying to view our practice as being more than just a 9-to-5 job or whatever hours it is you're working. It's thinking about our careers in public health, also from the lens of our lives in public health, because I think we're starting to realize more and more just how much we can't be separated from these realities. We can't be separated from the inequalities that are around us, but also from the possibilities for healthier futures. So there's so much more that we can unpack there. And, as I mentioned earlier, if anyone is interested in having more of a conversation in an informal format, please reach out to Heather. Maybe Heather, you could put your name in the chat again. But otherwise, just thank you. And I hope everybody enjoys the rest of their day and finds ways to nourish and find hope and joy today. Take care, everybody.
Thanks.